Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about lung cancer, but we'll start off with the solitary pulmonary nodule. Now, for all patients who may have lung cancer, regardless of its stage, regardless of the subtype, only about 15% of them will survive after 5 years. Tobacco smoking is thought to cause 80 to 90% of lung cancers, and almost all cases of squamous cell and small cell carcinoma of the lungs are seen in smokers. Adenocarcinoma is also associated with smoking, but if you have a patient who has no history of smoking whatsoever, no secondhand exposure, more likely than not, such a person with bronchogenic carcinoma would most likely have adenocarcinoma and not squamous cell carcinoma. Some occupational and environmental exposures include beryllium, radon, arsenic, among others, and these remain very important risk factors for lung cancer. Asbestos exposure, right now asbestos exposure has reduced because we've changed our roofing materials, but back in the day, asbestos exposure was a major risk factor for lung cancer, and it increases your risk of lung cancer by a factor of 5, very similar to smoking. Then pulmonary fibrosis, pulmonary scarring from prior TB or other causes of fibrosis can also increase your risk for lung cancer. So now to talk about solitary pulmonary nodules, just an overview. A solitary pulmonary nodule is a well-defined round or oval lesion in the lung parenchyma measuring less than or equal to 3 centimeters. If a lesion is more than 3 centimeters, it's no longer called a nodule, it's now called a mass. Some differential diagnosis would include neoplastic, inflammatory, or congenital etiologies. Some common mimics that we may see on a radiograph may include a nipple shadow. You may see a rib lesion superimposed on the lung and think it is a lung nodule, or even summation of markings on the lung may produce a nodule-like appearances. So this X-ray shows these well-defined rounded nodule-like structures here and here in the left and right lower lung zones. By looking at the bilateral nature and where they are located, these were found to be the patient's nipples. Then talking about solid pulmonary nodules, when you have calcified nodules, including central, diffuse calcifications, any kind of calcification of these sorts are most likely benign calcifications. Popcorn calcifications would suggest a pulmonary hematoma, and a pulmonary hematoma is a benign tumor that is composed of connective tissue, muscle, fat, bone, and cartilage. Now, some non-calcified nodules can be benign or malignant. If you have a nodule that has intralesional fat within it, it's suggestive of a hematoma or a lipoid granuloma, which is benign. Then amorphous calcifications that are so tiny that you can't really tell their shape or morphology, are usually associated with malignancy. So this image, for instance, is a non-contrast chest CT, and this is in the bone window, and it shows a soft tissue mass here with popcorn-like calcifications in the left upper lobe, and this is consistent with a benign hematoma. Now to talk of pulmonary nodule morphology that suggests benign lesions, if the nodule is less than 3 millimeters, it has a 0.2% chance of being cancer. If it's between 4 to 7 millimeters, it has a 2.7% chance of malignancy. When you have oblong, polygonal, triangular, flat nodules, they are typically intrapulmonary lymph nodes. When they have a subpleural location, they could also be lymph nodes, and they are also usually benign in the subpleural location. Now, clusters of nodules also suggest infectious process or inflammatory process, which are also benign findings. So in this first CT scan is an example of a subpleural nodule, which was found to be a subpleural nodule, very benign. And then this CT scan, the second CT scan, the lower one, shows clustered nodules at the site of an infection. You can see multiple clustered nodules here. Also a benign finding. Large size is the single most important risk factor for malignancy, regardless of the morphology. 0.8 to 3 centimeter nodules have 18% risk of being lung cancer, and masses that are more than 3 centimeters have a high chance of being malignant. Irregular edge or speculated margins also have a high chance of being malignant. So this image shows a solitary pulmonary nodule with speculated margins, suggestive of bronchogenic carcinoma. Now, we may have some nodules that are not exactly solid, but are more dense than lung parenchyma. So we are talking about subsolid nodules. Subsolid nodules could either be ground glass, mixed, or cavitary. A ground glass nodule is a nodule that is denser than the lung parenchyma, but less dense than the blood vessels. A solid nodule, on the other hand, is a nodule that has similar density to the blood vessels in the lungs. Now, a mixed nodule in this case is going to be a nodule that has both solid components and ground glass components. And these nodules are more likely to be malignant than a solid nodule. So you should be very careful of ground glass nodules and mixed attenuation nodules. A cavitary nodule, or a nodule that contains multiple cystic spaces, is also quite suspicious for malignancy. So in this image, it shows a part solid nodule which has both ground glass attenuation and solid components. Very suspicious. Now, follow-up is not really recommended for low-risk patients with solitary or multiple pulmonary nodules that are less than 6 millimeters. So we should have this number 6 millimeters in our minds. Once we are evaluating nodules and you measure and they are less than 6 millimeters, they are usually not suspicious. Now, you also combine the findings of the nodule with the patient's history to see if this patient is a high-risk patient or a low-risk patient. If it's a low-risk patient, then you are good. Any interval nodule growth is suspicious. So a 26% increase in diameter, for instance, let's say from 1.0 to 1.26 centimeters, actually is a doubling in volume. So you are increasing the diameter by 0.26, but the volume is actually doubled if you do the calculation. Doubling time for lung cancers ranges from 42 days in very aggressive tumors to even over 4 years in indolent lesions. Now, if you see a solid nodule with well-defined benign morphology that has not changed in size over 2 years, it's very likely, but not definitely, benign. Longer follow-up is recommended for subsolid nodules, since these often represent indolent adenocarcinomas. Now, if you see a decrease in size of a suspicious nodule on just a single follow-up, that's not sufficient enough for you to establish a benign etiology, because it's possible to have transient decrease in size of malignant lesions, and this can occur when, let's say, you have a collapse of an aerated alveoli or due to fibrosis. You may have some transient decrease in size, so just a single follow-up is not enough. You may require further follow-up to establish benign nature of some of these nodules. Now, for a more detailed guideline of the management of pulmonary nodules, you can check out the Fleischner Society guidelines. I think the most recent one was in 2017, as at the time of the making of this video, so you can check that out. Thank you very much for your attention. The next topic we'll talk about is the histologic subtypes of lung cancer. I hope, as usual, you are finding value with these lessons, and if you are, share to someone you think would also need it. Give it a like, subscribe if you have not yet subscribed, and leave a comment. All right, thank you very much, and I will see you in the next one.